We're continuing on with part 3 of Unit 13. In warm autoimmune hemolytic anemias, we do warm autoabsorptions. For cold autoimmune, we do one of two types of autoabsorptions that we'll talk about. The rabbit erythrocyte stroma test, also known as REST, and a cold autoabsorption. We're going to talk about the rabbit erythrocyte stroma test first. And this is for patients who have been recently transfused, for which we cannot do an auto-adsorption, meaning absorbing the antibody onto the patient's own cells, because we may be absorbing out an alloantibody. So again, if your patient has been recently transfused, this is the path for you. It was discovered that rabbit cells have the I antigen. And the rabbits are bled, the cells are hemolyzed, that only the membranes or the stroma of the red cell remain. And I want to assure you that they do not sacrifice the rabbits. These are the most well taken care of rabbits in the world. What they do is they harvest a certain amount of blood, 10%, 15% of their blood supply, and then they allow them time to rebuild. So that they have this whole farm of rabbits. So when they hemolyze it, these membranes are very, very light and fluffy. And I wish, I'm hoping your instructor has something that he can show you. So the procedure, I've done this many times, is you incubate the patient's serum or plasma with the rabbit stroma at 4 degrees centigrade. This is where the antibody likes to react the best. So what happens is the anti-big I goes onto the stroma that has the I antigen, and it's absorbed out. It's removed. Then you spin this down, and then you harvest the serum or the plasma, and you test the absorbed serum against the screen cells. So if the screen cells are still reactive, then you may have to do this a second time. Use that same aliquot on a new aliquot of the red cell stroma from the rabbit. You have to use this with caution because it may adsorb out clinically significant antibodies to DE, VEL antigens, and IgM antibodies regardless of specificity. A traditional cold autoabsorption test, meaning incubating patient serum with patient cells, is very, very easy to do. Big disclaimer, you cannot do an autoabsorption on a recently transfused patient because you may end up adsorbing out an alloantibody in addition to the auto. So you want to collect an EDTA sample and keep it warm and separate the plasma from the red cells. Then you wash the red cells with warm saline. Now the cells are coated with a cold reacting antibody. At 37, what happens to those cold reactive antibodies? They come off. They dissociate from the cell. And then you add an aliquot of the plasma or serum to the red cells, and you incubate at 4 degrees for 1 hour. Then you harvest the plasma and test it against the screen cells. If it's negative, there's no alloantibody. If it's positive and negative, that indicates that perhaps an alloantibody is present and you want to run a panel. If they're still all positive, the autoabsorption was unsuccessful, so you repeat again with the one-time absorbed sample. And what I have found when we have samples is I like to immediately stick the sample where I want to harvest the serum from in the refrigerator, because that's kind of like a first adsorption. And then I harvest that serum and I add it to the cells that were warm and washed with warm saline. And so I find that I can get through a bit quicker. So this should be in your SOP if that's allowed, but this is one way that I was able to decrease the number of autoabsorptions that I had to do. So the procedure for a cold autoabsorption, in this sample we have two types of antibodies. We have the alloantibody, which is an IgG in green, and we have the IgM autoantibody in purple. And remember, IgMs are a pentamer with 10 antigen binding sites. So you spin down the sample, remove the supernatant plasma, then you wash the cells 3 times with warm saline. What that's going to do is it will cause the autoantibody to dissociate. So you're washing with 37-degree saline. Then you incubate the patient's serum with these washed cells, which are now naked, they don't have the antibody on them, at 4 degrees. What's going to happen at 4 degrees? The autoantibody, the anti-big I, will attach to the patient's cells again. And what's going to happen is it will then leave the IgG free in the supernatant fluid, because IgG does not attach to cells at 4 degrees centigrade. So you spin down the sample and now you're ready to test. So you use the supernatant for the antibody screen, the reverse grouping, and the auto control. Unfortunately, some autoantibodies are so strong that this will not remove them completely. So you may have to do this up to 3 times. And again, follow your SOP, but after 3 times, the weakening of the reaction may be due to the dilutional effect rather than a decrease in the autoantibody due to autoabsorption. The good news is, for transfusion, they rarely require transfusion. And if you do have to transfuse, you can use the pre-warm technique for compatibility tests or use the cold auto-adsorbed serum. And if you remember, in the pre-warm technique, you pre-warm an outclot of serum, you put your 3 screen cells in labeled tubes, put a drop in each of those tubes, put it in the 37-degree heat block, 10 minutes, 5 minutes. Then you add the pre-warm serum to the pre-warm cells, incubate for 30 minutes because you're not going to add a potentiator. So you have to do a maximal incubation time. Then, without removing those tubes from the heat block, you will add your pre-warm saline for the first wash and then continue with the 3 washes. And if it's really, really strong, then we're going to transfuse through a blood warmer. And there's this little 3-minute video I would encourage you to watch, which describes how these transfusions are done through the blood warmer. So if you know a patient has a strong cold auto, how do you avoid cold autoantibody reactivity? First, avoid anti-complement in the AHG test. Use the monospecific IgG rather than polyspecific. And if this is an IgM antibody that does not have high thermal amplitude, then you should have negative testing throughout. If it is an antibody with high thermal amplitude, avoiding cold autoantibody reactivity, avoid anti-complement in the Coombs test. Use monospecific IgG rather than polyspecific. Eliminate the immediate spin and 37 readings if you're dealing with a cold autoantibody that has high thermal amplitude, meaning it's there at immediate spin, it's there at 37, and because it did not dissociate, it will still be there at Coombs. Avoid the use of Lys enhancement. Use 22% bovine serum albumin instead of Lys, and you will need to increase the incubation time. Bovine albumin is usually a 20-minute incubation time. And perform the pre-warm technique if those don't work. This chart summarizes the differences between warm versus cold autoantibodies. I'm not going to read it to you, but again, it just summarizes in one place what the differences are so far as temperature of reactivity, antibody versus complement, and the signs and symptoms. And the last type of autoantibody I'm going to talk about is the mixed type. 1/3 of patients with warm autoimmune hemolytic anemia have non-pathologic IgM antibodies reactive at 37. And the mixed type can be further divided between patients with high titer, high thermal amplitude IgM versus those patients with normal titer, less than 64, high thermal amplitude IgM. These often present with hemolysis and complex serum reactivity present in all phases of testing, from immediate spin to Coombs. The DAT, both IgG and C3d are detectable as proteins on the red cell, IgG due to the warm autoantibody, and C3d is bound due to the IgM autoantibody. In serological testing in a mixed type autoantibody situation, first, the serum or plasma, the cold, can have anti-big I or little I specificity, but often has no specificity. It's just making cells agglutinate in the cold. Warm is serologically indistinguishable from traditional warm autoantibodies. The eluate, the activity is indistinguishable from warm auto because there is IgG coating the cells. Adsorptions may be necessary to perform at both 37 and 4 degrees. So what you might want to do is get your sample, stick it in the fridge, and that can be an initial cold autoabsorption, and then harvest that serum or plasma, and treat it as you would a warm auto. So again, just follow the SOP and the guidance of your mentors in the transfusion service. Transfusion considerations are identical to those described for the warm autos. And if the cold is really strong, then you may also want to use a blood warmer. Paroxysmal cold hemoglobinuria, also known as PCH, is the rarest form of DAT positive autoimmune hemolytic anemia. It's different from paroxysmal nocturnal hemoglobinuria, in which hemolysis is caused by acid produced during sleep. So don't get those two confused. PNH versus PCH. The PCH presents as an acute transient condition secondary to viral infections, particularly in young children. It's caused by biphasic hemolysin, which we will discuss later on in this presentation, which induces hemolysis after exposure to the cold. This results in hemoglobinuria and hemoglobinemia. The serological workup is the same because it's an autoantibody, so you're going to do a DAT and an eluate. And the DAT, this is fascinating about this disease. The autoantibody is IgG, which acts as a cold agglutinin. Is that weird? So what happens is the IgG binds to red cells in the colder parts of the body, the peripheral circulation. This causes complement to be bound irreversibly. Nothing you can do can make that complement come off. The IgG elutes off of the red cells in the warmer parts of the body, and only complement is detected. The eluate, since only complement coats the cells, the eluate is negative, and this you must memorize. The antibody specificity is anti-P, not anti-P1, just anti-P. And it's not necessary to transfuse rare P-negative blood. In paroxysmal cold hemoglobinuria, the autoantibody is described as a biphasic hemolysin. So there's two phases that which will then result in hemolysis. The antibody will bind to the red cells at low temperatures, which also binds complement. As the cells warm up, complement is activated and hemolysis occurs. This is the basis of the Doneth-Landsteiner test. And it's so funny. I always thought hematology did the test. Hematology thought we did the test. And in fact, it turns out it was a send-out test, which makes sense because this is the rarest form of an autoimmune hemolytic anemia. So in the Doneth-Landsteiner test, it's used to detect this biphasic antibody. And usually you add fresh serum as the source for complement. And as the antibody binds at cold temperatures, the test is warmed to 37. As warming occurs, complement is activated and lysis of red cells occurs. The autoantibody in paroxysmal cold hemoglobinuria is described as a biphasic hemolysin. There's two phases to get reactivity. In the first, the antibody binds to red cells at low temperatures. this also binds complement. As the cells warm up, complement is activated and hemolysis occurs. And this is the basis of the Doneth-Landsteiner test. So let's talk about it step by step. So again, it's used to detect the biphasic antibody. You add fresh serum as the source for complement because remember, as the specimen ages, within 24 to 48 hours, the complement levels decrease tremendously. So the presence of antibody and complement will bind at cold temperatures. Then the test is warmed up to 37, and as warming occurs, the complement is activated and lysis of the red cells occurs, which is a positive result for this test. I don't expect you to memorize this, but just know that the contents of each tube is different. And the reason is we want to have controls in it to determine whether or not the autoantibody is present. So this slide represents the results of a Doneth-Landsteiner test result. So in each of the tubes labeled with a 1, this contains 10 ml of patient serum. So it'll have complement and autoantibody. In the 2 series, this has 5 ml of patient serum and 5 ml of fresh complement, which if the complement levels have gone down, this will provide a fresh source. And in the 3 series, all that's present is 10 ml of fresh donor serum. No patient serum, so no autoantibody present. So the A series is incubated at 0 degrees for 30 minutes, which allows for attachment of the IgG and also attachment of complement. And then at 37 degrees for 60 minutes, which this is when the antibody will come off, the complement is present, and this will result in activation of the complement and hemolysis of the cells. The B series is incubated at 0 degrees for 90 minutes, and then the C series is 37 for 90 minutes. Remember, this autoantibody is a biphasic hemolysin. There must be incubation at 0 degrees and incubation at 37 in order for this autoantibody to cause hemolysis. So if you look at A1 and A2, which has both patient serum that contains the autoantibody and fresh complement, and it's incubated at both 0 degrees and 37, complement is activated and hemolysis occurs. In the other ones, the conditions are not right for a biphasic hemolysin, so all of those will be negative. So this is a positive test for the Doneth-Landsteiner autoantibody. This concludes part 3 of Unit 13.